Assalamu alaikum. I'm Professor Dr. Haidar Jawad Mubarak. I will present to you practical session for revising anatomy of the abdominal wall, specifically the anatomy of the anterior abdominal wall. The anterior abdominal wall is smaller than the abdominal cavity because part of the abdominal cavity extends deep to the ribs and costal margin, and also part of the abdominal cavity extends deep into the bony pelvis, and so the anterior abdominal wall is smaller than the size of the real abdominal cavity. Therefore, if we want to have some points on surface anatomy of the anterior abdominal wall, we have to say that the anterior abdominal wall is limited above by the costal margin, which is this 7, 8, 9, 10 costal cartilage, and also the anterior abdominal wall is limited above by the infrasternal angle that contains the xiphoid process. This angle is at the level of the T9 vertebra. This is the surface anatomy superior boundary of the anterior abdominal wall, costal margin and the infrasternal angle. While inferiorly, the surface anatomy for the boundary of the anterior abdominal wall is found by the following. Number one, the iliac crest. The highest point of the iliac crest lies at the level of L4 vertebra, and then the other point in the inferior boundary of the anterior abdominal wall is the anterior superior iliac spine, which is the anterior end of the iliac crest. It lies at the level of S1, sacral 1 vertebra, and then the inguinal ligament limits the anterior abdominal wall inferiorly, and then the pubic crest, which is the upper border of body of pubis. You know, the inguinal ligament extends from anterior superior iliac spine to pubic tubercle, and more medial to pubic tubercle. The inferior boundary of the anterior abdominal wall is the pubic crest. So these are the superior and inferior boundary of the anterior abdominal wall on surface anatomy. Other points in surface anatomy is the umbilicus. You can see that the position of the umbilicus in a slim person have an important anatomical landmark for the disc, intervertebral disc between L3 and L4 vertebra. The costal margin, as we said, is formed by the 7, 8, 9, 10 costal cartilage, and if we have an imaginary line between the lower border of the 10th rib on the right and left side, this plane is called subcostal plane because it is below the lowest rib, which is the 10th rib. This level, the subcostal plane at the lower border of the 10th rib, is at the level of the L3 vertebra. Also, as part of the surface anatomy, you have to say something about the Langer's line, which are lines of arrangement of collagen in the dermis, which are called also cleavage lines or Langer's line. Langer's line are running horizontally in the anterior abdominal wall, and therefore surgical incision should be better done with the direction of the Langer's line in order to have a minimal scar after suturing the wound. Other surface anatomical landmark are the following. Linea alba. This is linea alba. It is a groove in the midline of the abdomen extending from the xiphoid process, as we said, which is at the level of T9 to the upper border of the symphysis pubis, which is at the level of the tip of the coccyx. This linea alba, the groove which is seen on surface anatomy, is considered as connective tissue in the midline, giving origin to flat muscles of the anterior abdominal wall. The other is linea semilunaris. This is linea semilunaris. It is a groove on the surface anatomy of the anterior abdominal wall formed by the lateral border of rectus abdominis muscle. It extends from the 9 costal cartilage down above to the pubic tubercle below. The other is tendinous intersection, or called linea transversalis or transversa. These are grooves appearing horizontally on the rectus abdominis muscle that are representing tendinous intersections of these muscles. These are 3 in number. The grooves, one of them is at the umbilicus, the other is at the xiphoid process, and there is one between the two. If you did an incision in the anterior abdominal wall for a surgery or something, you must cut the following layers of the anterior abdominal wall. First, the skin. Next is the superficial fascia, and you can see that the superficial fascia is formed of 2 layers. Fatty superficial layer of superficial fascia, which is called fascia of Camper, contains much of fat, and deep to it is the membranous deep layer of superficial fascia, which is called scarpa fascia. So the superficial fascia is formed of 2 layers: Camper's fatty superficial layer and membranous scarpa fascia. Deep to the scarpa's fascia is the deep fascia, and actually the deep fascia here is only represented by the epimysium of the muscle. It is only a thin deep fascia, and then you will have extra peritoneal connective tissue. Of course, we have the last deep fascia is fascia transversalis, which is fascia of transversus abdominis, surrounding transversus abdominis muscle. And next to fascia transversalis is the extraperitoneal connective tissue, and then the peritoneum, which lines the anterior abdominal wall, that is called parietal peritoneum, just like that of the pleura, parietal pleura lining the chest wall. So the layers are 6: skin, superficial fascia with its 2 layers, the muscles of the anterior abdominal wall with the epimysium that forms its deep fascia, the fascia transversalis, which is fascia deep to transversus abdominis. It is also considered as a deep fascia. Then extraperitoneal connective tissue, which is loose tissue, then parietal peritoneum. For clinical examination, we may have to divide the anterior abdominal wall into regions in order to be able to describe the clinical features or describe diseases or symptoms or signs of diseases. So we have one method of dividing the anterior abdominal wall is region is the 4 quadrants. Here you have to do intersecting lines that are intersecting at the level of the umbilicus. These vertical and the transverse intersecting lines divides the anterior abdominal wall into 4 quadrants: upper and right and lower right, upper left and lower left. So you can see, for example, there is a pain in the upper right quadrant. You can write this in the case sheet, or you can say that there is a mass during examination felt in the upper right quadrant of anterior abdominal wall. Or the other way is not quadrant way, is the 9 region way. Here you may use 2 parallel vertical lines and 2 parallel horizontal lines to divide the anterior abdominal wall into 9 regions. The vertical lines, the 2 parallel vertical lines, are the lines at the mid-clavicular point. Vertical lines are passing into the mid-clavicular point. This vertical line above is crossing the mid of the clavicle, but at the costal margin it crosses the 9 costal cartilage, and down it will cross the middle of the inguinal region, which is the mid-inguinal point. The mid-inguinal point is the middle between the anterior superior iliac spine and the pubic symphysis. It is not in between the middle of the anterior superior spine and the pubic tubercle. Between the anterior superior iliac spine and the pubic tubercle, this is the middle point of inguinal ligament. I'm saying mid-inguinal point, which is between the anterior superior iliac spine and the pubic symphysis, not pubic tubercle. So the vertical line extends from the middle of the clavicle, 9 costal cartilage, and the mid-inguinal point. These are right and left vertical plane. The horizontal planes or the transverse planes that divide the abdomen into 9 regions include the upper one, which is a transpyloric plane. This is a plane at the level of the first lumbar vertebra, passes in between the right and left 9 costal cartilage, and sometimes we are using the subcostal plane, which is at the level of the T10 vertebra, T10 rib, the 10th rib. We have a level horizontally extending between the lowest point of the ribs, which is the subcostal plane. Some of the textbook involves transpyloric, the other involves subcostal plane. They are the same, but of course the subcostal is at L3, but it could be used to divide the abdomen into 9 regions also in some textbook. But we will consider the transpyloric, which is at the level of the L1 vertebra, passing at the level of the 9 costal cartilage, and it is located in the middle between the suprasternal jugular notch and the pubic symphysis. The mid between the suprasternal jugular notch and the pubic symphysis is the transpyloric plane. The other horizontal plane or a transverse plane is a transtubercular plane. You know, the anterior superior iliac spine ends anteriorly, the iliac crest and anteriorly by the anterior superior iliac spine. If you go 5 centimeters behind the anterior superior iliac spine, you will find the tubercle of the iliac crest. And the horizontal line between the right and left tubercles of the iliac crest is the transtubercular plane or intertubercular plane. It is at the level of the 4th lumbar vertebra, and by that you have divide the abdomen into 9 regions, namely the right hypochondrium, the left hypochondrium, and between them is the epigastrium and the right lumbar region, left lumbar region, and in between them is the umbilical region, and then the right iliac or inguinal region, the left iliac or inguinal region, and in between them is the hypogastric region or hypogastrium. And these are the name of the regions. Each of these regions, sometimes textbook reporting that these regions are related to surface anatomy of organ. For example, the hypochondrial region on the right side is related to the liver. The epigastrium is related to the liver, stomach, and pancreas. The lumbar region related to colon, and so on. And it is reported here. But I think these are variable location and may be used for academic purposes. The hypogastric, you can read it, the hypogastric or suprapubic. The hypogastrium, also called suprapubic region, as the iliac is called inguinal region also. Both of them are related to structures. For example, hypogastric or suprapubic is related to the urinary bladder when it is full, to the uterus when it is pregnant, and to small intestine. And these are the regions, the surface anatomy for the organs underlying, and that is also. Considering nerve supply of the anterior abdominal wall, we may say that The nerve supply to the skin and muscles of the anterior abdominal wall, and also supplies the parietal peritoneum lining the anterior abdominal wall, are the spinal nerves, which are the lower 6 thoracic nerves and the first lumbar nerve. That's why there is an example for a clinical application for this nerve supply, which is similar to that in the pleura. The parietal peritoneum, because it has the same nerve supply as the muscles and the skin, so the parietal peritoneum is pain sensitive. And that's just like the pleura. The parietal peritoneum lines the interior abdominal wall, and there is another layer which is visceral peritoneum covering the abdominal viscera. And the visceral peritoneum is supplied by autonomic sympathetic nerve and parasympathetic nerve, and so the visceral peritoneum is poor sensitive to pain, while the parietal peritoneum is very sensitive to pain. So if you have inflammation of the appendix, which is called appendicitis, the appendix will enlarge, and such enlargement will produce tension on the peritoneum of the appendix, which is visceral peritoneum. This tension will produce pain transmitted via the autonomic nerves, via the sympathetic nerve. And so the patient at the early appendicitis, acute appendicitis, will feel vague pain around the umbilicus, because the dermatome of the umbilicus is the T10, and the sympathetic innervation to the appendix is from T10. So early inflammation of the appendix will produce revert pain around the umbilicus, but later on the inflamed appendix will enlarge much in size, and because it will be swollen, it will be in contact with the parietal peritoneum on the right iliac fossa, so there will be a shifting of pain from the early pain around the umbilicus to pain in the right iliac fossa, which is the region of the appendix. This shifting of pain is due to transmission of feeling of pain from an early sympathetic pathway, which is visceral peritoneal nerve, which is autonomic T10, to pain at the parietal peritoneum, which is at the right iliac fossa, that is sharp, localized, due to enlargement of the appendix, and this large appendix will touch the parietal peritoneum in the right iliac fossa, leading to pain in this fossa. So there will be shifting of pain from periumbilicus to right iliac pain, because the pain early is visceral, from visceral peritoneum, transmitted by sympathetic nerves, but later on it will be parietal peritoneal pain, somatic pain localized here in the position of the right iliac fossa. So, as we said, the anterior abdominal wall is supplied by nerves, which are the lower 6 thoracic nerves, that are 5 intercostal and subcostal, and also from the first lumbar nerve. Surface anatomy is very important in nerves of the anterior abdominal wall. You can see that T7, which is the first thoracic nerve, supply the skin and muscles and peritoneum and the epigastrium below the sternum, and then followed by T10, T9, T7, T8, T9. T10 is at the umbilicus, below it is T11, T12, and T10, L1 will be above the pubis in suprapubic or hypogastrium region. Actually, the L1 is represented by two nerves, which are ilioinguinal nerve and iliohypogastric nerve. These are the L1 nerves supplying the anterior abdominal wall. All of these nerves run in between the internal oblique muscle, which is a flat muscle of the anterior abdominal wall, and the transversus abdominis muscle. And this position where the nerves are running is called the neurovascular plane, similar to the neurovascular plane seen in the thorax in between the internal intercostal muscle and the innermost intercostal muscle. So here the plane or the space between transversus abdominis muscle and the internal oblique, this is transversus abdominis, this is internal oblique, is called the neurovascular plane. It contains these nerves, as you can see. Similarly, this plane transmits the vessels. However, the vessels of the anterior abdominal wall are of two types or two regions, vessels in the midline and vessels in the flanks. Vessels in the midline are represented by the superior epigastric artery, which is a branch of the internal thoracic artery that runs behind the sternum and divides in the 6 intercostal space into musculophrenic and superior epigastric. This superior epigastric artery runs with the rectus abdominis muscle inside the rectus sheath, and it runs usually behind the rectus abdominis muscle. As you can see, you must remove the rectus abdominis muscle to see the artery behind it. And also in the midline you have, in addition to the superior epigastric above, you have inferior epigastric artery also running in the rectus sheath. This inferior epigastric is a branch from the external iliac artery, and it enters the rectus sheath by crossing the lower border of the posterior wall of rectus sheath, which is called arcuate line. This inferior epigastric artery in this region gives branches to cremasteric muscle and to pubic arch. Arteries in the flanks, the second group, includes intercostal artery, subcostal artery, lumbar arteries, deep circumflex iliac artery, which is a branch from the external iliac artery. Also, we have branches that are seen here supplying the flanks, which are branches of the femoral artery, including DC3, the superficial epigastric artery, the superficial external pudendal artery, and the superficial circumflex iliac arteries. This is a diagrammatic representation that probably will make remembering of the branches of the arteries supplying the anterior abdominal wall much easier, especially the flank group. Venous drainage carries an important clinical aspect. Cutaneous veins, or veins of the anterior abdominal wall, are called to represent a watershed line, because the flow of blood in the cutaneous veins is going upward in the region above the umbilicus and going downward in the region below the umbilicus. And so the umbilicus, because the blood in the vein goes above it superiorly and below it inferiorly, the umbilicus is considered as the watershed line for the anterior abdominal wall venous drainage. Of course, the blood that goes above the umbilicus upward, it will reach the axillary vein, and it will reach the brachiocephalic vein. And that blood which goes below, it will reach, of course, after the blood that goes above, that goes to the axillary vein and the brachiocephalic vein, finally will be, these two veins will be tributaries or convey blood to the superior vena cava. So all the veins, the venous blood going up above the umbilicus, going to the axillary vein and the brachiocephalic vein, then they will be finally reach the superior vena cava. But bloods below the venous blood below the umbilicus are going downward, finally will reach the inferior vena cava. So the watershed line of venous blood, or the blood above the umbilicus, goes to superior vena cava finally, and all the blood below the umbilicus go finally to inferior vena cava. Of course, that which goes above to superior vena cava goes via the lateral thoracic vein, that is tributary of the axillary vein, and superior epigastric vein, that is a tributary of the internal thoracic vein, which ends into the brachiocephalic vein. Of course, the superior epigastric vein runs with the superior epigastric artery inside the rectus sheath. The veins that are below the umbilicus include veins which are tributaries of the femoral vein, having the same names of the veins of the arteries from the femoral artery, which are superficial epigastric, superficial circumflex iliac, and superficial external epidendal, and also include the tributaries of the external iliac vein, which are inferior epigastric vein, deep circumflex iliac vein. And so these are the veins watershed line around the umbilicus. In addition to these, some of the veins of the anterior abdominal wall drain to the paraumbilical veins that are running in the ligamentum teres, that is located at the lower border of falciform ligament of the liver. And these veins, the paraumbilical veins running in the falciform ligament and the round ligament, ends finally into the portal vein and the hepatic venous circulation. Here the round ligament is called round ligament. This is the synonym, round ligament or ligamentum teres. So the paraumbilical veins also draining the anterior abdominal wall vein to the paraumbilical veins. Paraumbilical veins are running in the ligamentum teres at the lower border of falciform ligament. Finally, these veins are connected with the portal vein and the hepatic venous drainage. What is the importance of that? Sometime there will be liver cirrhosis. In case of liver cirrhosis, because the liver will be fibrosed, so the venous blood in the portal vein will not be able to pass into the liver and then from the liver to inferior vena cava and then to the heart. Because the liver is fibrosed and the venous drainage is obstructed. So the blood from the portal vein, when it will reach the liver, it will go back via the paraumbilical veins to the umbilicus. And this portal vein, portal blood, when it goes back via the paraumbilical vein, this portal venous blood will accumulate around the umbilicus. And from the umbilicus, this portal venous blood will ascend up to the superior vena cava and down to inferior vena cava as an alternative pathway, because the liver is obstructed. It will not allow passage of portal venous blood. So the return of portal venous blood to the paraumbilical vein and then the umbilicus and then going superiorly to superior vena cava, inferiorly to inferior vena cava, results in dilatation of the veins around the umbilicus, producing a rosette-like configuration, which is called caput midozzi. You will find that the anterior abdominal wall shows dilated vein radiating from the center of the umbilicus. And if you follow the blood flow in these veins, you will find it normally passing above the umbilicus above and below the umbilicus below, as the umbilicus is a watershed line. Similarly, sometime you may have obstruction to either the superior vena cava or inferior vena cava. You will find also dilated veins in the anterior abdominal wall, but not looking like a caput midozzi. You will find a single vein coming from up down, which is dilated vein. So if you follow the blood flow in this vein, and you will find it below the umbilicus going up, which is not normal. That's mean obstruction of the inferior vena cava, and thus the blood in the vein below the umbilicus is not going normally below. It is going abnormally above, because it couldn't go below as the inferior vena cava is obstructed. And similarly, if you'll find that this single dilated vein shows above the umbilicus blood flow down, it must be above the umbilicus up. No, you will find it down, running the blood flow. This means that the superior vena cava is obstructed, and all the blood going to the superior vena cava is deviated to the inferior vena cava, and so you will find the dilated vein above the umbilicus have a blood flow abnormally downward. The normal is upward. Similarly to the venous drainage, lymphatic drainage of the anterior abdominal wall also follows the watershed line strategy of the umbilicus. As veins of the anterior abdominal wall goes up above the umbilicus, reaching the axillary lymph node and the sternal lymph nodes, and also lymphatics of the anterior abdominal wall below the umbilicus go down to superficial inguinal lymph node. So lymphatics above the umbilicus go up to the axillary and the sternal lymph nodes. Lymphatics below the umbilicus go down to the superficial inguinal lymph node. Thus the umbilicus is a watershed line. Going deeper into the description of the anterior abdominal wall, the first thing that will be described is the superficial fascia, and we said that the superficial fascia is formed of two layers: fatty superficial fascia, which is fascia of Camper, that contains much of fat and continues with the fatty layers of the thorax and pelvis and perineum. And this fatty superficial fascia is replaced in the scrotum by a muscle which is called dartus muscle. Deep to this fatty layer is a membranous layer which is scarpa fascia. The scarpa fascia continues with the membranous superficial fascia of the perineum, which is called Colles fascia. As we said, the deep fascia is not real deep fascia. It is a thin fibrous tissue, connective tissue, covering the muscle, so it representing the perimysium of the muscle. Considering more deeper layer than the superficial and deep fascia, we have to talk about the muscles. Muscles of the anterior abdominal wall are the lateral flat muscles, which are from outside to inside, external oblique, then internal oblique, then transversus abdominis. These muscles are represented by fleshy muscular tissue posteriorly and laterally, but anteriorly these muscles become aponeurotic, all of them. You can see the lateral and posterior part of the flat muscles is fleshy, red in color, while the interior part of these muscles is white, aponeurotic. In addition to the three flat muscles, laterally and posteriorly, anteriorly, you have the rectus abdominis muscle. The flat muscles, external oblique, internal oblique, and the transversus abdominis, surrounds by their aponeurosis the rectus abdominis muscle. And when the aponeurosis of external oblique, internal oblique, and the transversus abdominis surround the rectus abdominis, the wall surrounding this rectus is called rectus sheath. Also, we have to say that the lower fiber of internal oblique and the transversus abdominis extend into the coverings of the spermatic cord. The lower fibers of internal oblique and the transversus abdominis run with the covering of the spermatic cord. These extensions form the so-called cremasteric muscle and fascia. You will find that the internal oblique and the transversus abdominis, part of their origin is from the inguinal ligament. And these fibers of internal oblique and the transversus abdominis originating from the inguinal ligament form the cremasteric muscle and fascia that are part of the covering and content of the spermatic cord. Function of the anterior abdominal wall include support of the abdominal wall, protect abdominal viscera, compress the abdominal content during breathing, increase intra-abdominal pressure as in coughing or defecation or urination, and movement of the trunk and posture. All the muscles, the flat muscles of the anterior abdominal wall, which are external oblique, internal oblique, and the transversus abdominis, are supplied by lower 5 intercostal nerves and the subcostal nerve, and also are supplied by the first lumbar nerve. But rectus abdominis is only supplied by the lower 6 thoracic nerves, which are the lower 5 intercostal and subcostal, because these nerves are the only nerves entering the rectus sheath formed by aponeurosis of the flat muscles and surrounding rectus abdominis. L1 nerve, which is iliohypogastric, and ilioinguinal nerve, both these nerves, which are L1 nerves, do not pass into the rectus sheath, and so they are not supplying rectus abdominis muscle. So the flat muscles are supplied by the lower 6 thoracic nerves, and the L1, the rectus abdominis, is only supplied by the lower 6 thoracic nerves. Considering the details of the flat muscles of the anterior abdominal wall, starting with the most superficial, which is external oblique, this muscle originates from the lower atribs, and here it interdigitates with the serratus anterior and with latissimus dorsi. Its fibers are directed downward, forward, and medially. The insertion is into the fibrous tissue of linea alba that extend from xiphoid process to the pubic tubercle and pubic crest. The nerve is the lower 6 thoracic nerves and L1, which are iliohypogastric and ilioinguinal nerve. This is all about origin, insertion, nerve supply of the external oblique muscle, which is the first superficial flat lateral muscle, posterior lateral muscle. Another thing which must be described for the external oblique muscle, that the external oblique muscle has 3 free borders and 1 opening. The free border superiorly, this is it, on the costal margin, and there is a free border posteriorly. But the most important is the free border inferiorly, because this free border is represented by the inguinal ligament. And if you remember in the lectures of anatomy of the thorax, the inguinal ligament is defined as the lower free border of aponeurosis of external oblique muscle that extend from anterior superior iliac spine to pubic tubercle. So the inguinal ligament is the lower free border of the external oblique aponeurosis, and this external oblique muscle has also an upper border which is free and a posterior border which is free. Also in the aponeurosis of external oblique, you have one opening here which is called superficial inguinal ring. This opening is triangular opening along exit of the spermatic cord in male, or its round ligament in the round ligament in female. This triangular opening, which is an opening in aponeurosis of external oblique, the superficial inguinal ring, lie above and lateral to the pubic tubercle. It forms by medial and lateral crusts that are connected at the apex of this triangular foramen or open by a transverse fiber, which are called intercrural fiber. These are the intercrural fiber connecting the medial and lateral crura of the superficial of the triangular superficial inguinal ring, which is one opening in the aponeurosis of external oblique muscle. If you remove the external oblique, you will find deep to it internal oblique. Direction of internal oblique muscle fibers is on right angle to that of internal oblique. It is directed upward, forward, and medially. The origin is from the back, from the lumbar fascia, and the origin is also from the iliac crest, which is the anterior two-thirds of the iliac crest, and from the inguinal ligament, the lateral two-thirds of inguinal ligament. And before a while we had described that the inguinal fiber of internal oblique and the transversus abdominis gave rise to cremasteric muscle running in the covering of the cord. You can see this is a cremasteric muscle originating from the inguinal fiber of internal oblique and the transversus abdominis. So the origin of internal oblique is from the lumbar fascia, from the iliac crest, anterior two-thirds and lateral two-thirds of the inguinal ligament. The insertion of internal oblique is because the fibers are directed upward. They are inserted into the ribs, actually in the lower three ribs, and also the costal margin, which is found of 7, 8, 9, 10 costal cartilage, and also the insertion is into the linea alba, extending from the xiphoid process to the pubic symphysis. The inguinal fiber of internal oblique and transversus abdominis not only give cremasteric muscle, but they also form arch, which is this one. And medially, the aponeurosis of these inguinal fibers form a tendon, which is called conjoint tendon. So you can see that the fiber of internal oblique, and you will see that deeper to this inguinal fiber of internal oblique, the inguinal fiber of transversus abdominis, both inguinal fiber of internal oblique and transversus abdominis form an arch. And after arching, their aponeurosis, you know, the medial part of both muscles is aponeurotic. So the arching inguinal fiber of internal oblique and transversus abdominis medially form a tendon, which is called conjoint tendon, that is attached to the pubic crest. Transversus abdominis, this is transversus abdominis, have a transverse running muscle fiber. It lies deep to internal oblique. It originates from the lower 6 costal cartilage, where it interdigitates with the origin of the diaphragm. Also, it originates from the lumbar fascia, from the anterior 1/3 of iliac crest, and from lateral 1/3 of the inguinal ligament. The insertion is into the linea alba, extending from xiphoid process to pubic symphysis, and that's all. Rectus abdominis muscle. Origin is from here, from the pubic symphysis and pubic crest. Insertion is into the 5, 6, 7 costal cartilage and into the xiphoid process. Rectus abdominis is surrounded by the aponeurosis of the external, internal, oblique, and transversus abdominis. These aponeurosis form anterior wall and posterior wall surrounding rectus abdominis muscle. These walls form the so-called rectus sheath. Rectus abdominis, as we said in the surface anatomy, shows tendinous intersections that are one of the umbilicus, one of the xiphoid process, and one in between them. These tendinous intersections are firmly adherent with the anterior wall of rectus sheath, but they are not attached to the posterior wall of rectus sheath. So now we have to talk about the rectus sheath. It is defined as a sheath which is formed by aponeurosis of the flat lateral muscles, posterolateral muscles. It has an anterior wall covering the rectus abdominis muscle and posterior wall behind this muscle. The anterior wall fused with the tendinous intersection of rectus abdominis muscle. If you remove rectus abdominis muscle, of course you can see that the anterior wall of rectus sheath, which is this one, cover all the rectus abdominis muscle from origin, from the pubic symphysis and pubic crest to the insertion to 5, 6, 7 ribs. All the rectus abdominis is covered by the anterior wall anteriorly. But if you remove the rectus abdominis muscle to see the posterior wall of rectus sheath, you will find that deep to rectus abdominis muscle, the posterior wall is not extending from the origin to insertion. The posterior wall is limited from the costal margin down to this line, which is called the arcuate line. This is a line that representing the lower border of the posterior wall of rectus sheath. Below this line, you don't have posterior wall of rectus sheath. Here, rectus abdominis lie on fascia transversalis. You remember that deep to transversus abdominis is a fascia which is called fascia transversalis. We see that in the 6 layers forming the anterior abdominal wall. So because the posterior wall of rectus sheath stops here at the arcuate line, below this line, the arcuate line, rectus abdominis lie on fascia deep to transversus abdominis, which is fascia transversalis. This arcuate line lies at the level between, at the mid-level between the umbilicus and the pubic symphysis. The arcuate line is at the middle in between the umbilicus and the pubic symphysis. It represents the posterior, the lower limit of the posterior wall of rectus sheath. Sometime in you may find a small muscle, which is this one, anterior to the origin of rectus abdominis muscle. This muscle is pyramidal in shape and thus is called pyramidalis muscle. It originates from pubic crest, inserted into the linea alba, but it is inconstant finding. So we said that rectus abdominis muscle encloses rectus sheath encloses rectus abdominis muscles and pyramidalis if present. It is inconstant. Also, rectus sheath surrounds the lower 6 thoracic nerves, which are the lower 5 intercostal and subcostal, but the sheath does not enclose or contain the L1 nerve, the iliohypogastric and ilioinguinal. They are outside rectus sheath. Also, rectus sheath surround the superior and inferior epigastric vessels, which are lying deep to the rectus abdominis muscle. As you can see, when you move the rectus abdominis muscle, you will find the vessels. This is another view for rectus abdominis muscle and sheath with pyramidalis. So what form the anterior wall of rectus sheath? What form the posterior wall of rectus sheath? And please remember that the posterior wall of rectus sheath is not lying deep to all rectus abdominis. The posterior wall of rectus sheath stops there. And so we will discuss that with the layerings, formation of layers of the anterior wall and posterior wall of rectus sheath. When we want to describe what form the sheath, the anterior wall and posterior wall, we have to describe the formation in terms of the sheath above costal margin, the sheath between the costal margin and the arcuate line. And you know what is the arcuate line? It is at the middle between the umbilicus and the pubic symphysis. This line represented the lower border of the posterior wall of rectus sheath. Below it, rectus abdominis lie on fascia transversalis. So we have to describe what form the rectus sheath above costal margin, between costal margin and arcuate line, and below the arcuate line. Above the costal margin, the anterior wall of rectus sheath is formed by the aponeurosis of external oblique muscle only. And there is no posterior wall of rectus sheath here because the rectus abdominis is originating from the 5-6-7 costal cartilage. So posteriorly, you don't have posterior wall of rectus sheath because the muscle, which is the content of the sheath, is attached to the origin, the costal cartilage. So only you have anterior wall formed by the aponeurosis of external oblique. Second, between the costal margin and arcuate line, the aponeurosis of internal oblique splits at the lateral border of rectus abdominis muscle, which is called linea semilunaris in surface anatomy. Here the internal oblique aponeurosis splits into two laminae. Anterior laminae of internal oblique aponeurosis share with the aponeurosis of external oblique on formation of anterior wall of rectus sheath, and the posterior laminae share aponeurosis of transversus abdominis and formation of posterior wall of rectus sheath. So between the costal margin and arcuate line, the anterior wall of rectus sheath is formed by aponeurosis of external oblique and anterior lamina of aponeurosis of internal oblique. And the posterior wall of rectus sheath in this region between the costal margin and arcuate line is formed by aponeurosis of transversus abdominis and posterior lamina of aponeurosis of internal oblique. While below the arcuate line, there is only anterior wall of rectus sheath, as we said, because below arcuate line there is no posterior wall of rectus sheath. And here the anterior wall of rectus sheath below the arcuate line is formed by the aponeurosis of all the three muscles, the external oblique, internal oblique, and the transversus abdominis. And here rectus abdominis lie on fascia transversalis. Another thing of clinical importance is about Rizq theory. This is Egyptian anatomist putting an important theory since long time ago, and this theory make a dramatic change in surgery of the abdominal incision. Till a time ago, anatomists and surgeons considered that the linea alba is a fibrous tissue extending from the xiphoid process to pubic symphysis, and this linea alba, the fibrous tissue, gives insertion to aponeurosis of external oblique, internal oblique, and the transversus abdominis. Rizq find that the linea alba is not a fibrous tissue, giving origin to these muscles, to the flat muscles, and extending from xiphoid process to pubic symphysis. He finds that the fibers of these aponeuroses are crossing from the right to the left, or from the left to the right region at the linea alba. So the linea alba is a site of intersection of the aponeurosis of the flat muscles, the external oblique, internal oblique, and the transversus abdominis. Specifically, he found that aponeurosis of external oblique on one side crosses at the linea alba to be continued with the opposite aponeurosis of internal oblique. Why this is important? Because previously surgeons thought that the linea alba is a fibrous tissue. You can do a midline incision, a median incision in the linea alba, and opening the abdomen for surgery, and thus this is a fibrous tissue that when you suture it after operation, nothing will happen, because you are suturing, you are cutting the fibrous tissue and suturing fibrous tissue that will heal by fibrous tissue. But They found that after midline incision in the abdomen, many of the patients would show hernia here in the midline incision. And Rizq theory explained that. Rizq said that you shouldn't do midline incision in the linea alba because it is not a fibrous tissue, it is a site of intersection of aponeurosis of the flat muscles. Thus, when we cut the midline incision at the linea alba, you will disturb the strength of these muscles, resulting in weakness and thus resulting in hernia in this region. Surgical incisions are many. There are median incision, midline incision, which are either above the umbilicus or below the umbilicus. It leads to weakness according to Rizq theory. Or we may do a surgical incision vertically on the sides of the midline called paramedial incision. And there are many other types of incision. Of course, paramedian incision is better than the median incision. Why? If you will cut here in the paramedian, lateral to the midline, you will cut the anterior wall of rectus sheath, deviate rectus sheath, and then cut the posterior wall of rectus sheath and passing to the abdominal cavity. So after suturing, you will replace rectus abdominis muscle to its position. First, you will cut the anterior wall, deviate rectus abdominis, cut the posterior wall, and passing deep into the abdominal cavity. When you will suture the posterior wall with other structures and the anterior wall with other structures, replacement of rectus abdominis muscle, which we will deviate during surgery and replace it to its position after surgery. This position replacement of rectus abdominis will support the incision sutured anterior and posterior to it. So there will be minimal hernia because the site of incision on the side of the midline, the paramedian, will be protected by the support of rectus abdominis muscle. So paramedian incision done in the anterior and posterior wall of rectus sheath with retraction of rectus abdominis muscle, and thus the healing will be strong because this muscle will support the wound. We have many other types of abdominal incision. We don't want to pass through details. This is a view with a figure to the inside of anterior abdominal wall. You can see this is the urinary bladder, prostate. So I'm looking to the anterior abdominal wall from inside. Surely I'm looking to the peritoneum now. If you look to the abdominal wall from inside, you will find below the umbilicus folds of peritoneum. These folds include the following: one median fold, which is called median umbilical ligament or fold. It is produced by peritoneum covering a fibrous tissue called urachus, which is an embryological remnant in this region, extending from the apex of urinary bladder to the umbilicus. And the peritoneum covering this urachus fibrous tissue is called median umbilical fold or ligament. Of course, this is a peritoneal ligament. On the sides of this median umbilical fold are the medial umbilical folds, that are folds of peritoneum covering remnants of the obliterated umbilical arteries, left and right. And more laterally, you will find a fold of peritoneum, which are called lateral umbilical folds, that are folds of peritoneum covering the inferior epigastric artery branch of the external iliac artery that goes up to enter the rectus sheath, and in this region it will produce a fold called lateral umbilical fold or ligament. In addition to that, you may find a double fold of peritoneum extending from the liver to the anterior abdominal wall and to the diaphragm, which is called falciform ligament. The lower border of the falciform ligament is called ligamentum teres or round ligament, and I think you know that this ligamentum teres represents a ligament, fibrous tissue remnant of the left umbilical vein. And I think you remember that the falciform ligament and ligamentum teres containing the parambilical vein we had just described with the caput middosi in case of liver cirrhosis. I hope I'm helping. Thank you very much.